Welcome everyone to the Childhood Obesity Committee's annual education session. The theme of our session is how to start a bariatric program, and this is a particularly crucial topic because although multidisciplinary bariatric program requirements and guidelines have been well established, and many hospital systems seem quite interested in having a bariatric program, several barriers still exist to actually getting a program off the ground. Our first presenter will be Dr. Jeff Zeitzman, who will discuss the nuts and bolts requirements for a certified pediatric bariatric program. Dr. Mark Walkhan will then present the topic, Making the Financial Case, Convincing Your Healthcare System to Support Your Program. And finally, Dr. Evan Nadler will talk to us today on navigating insurance coverage.
Good morning. I'm Jeff Zeitzman, and for the next few minutes, I'm going to talk to you about developing an adolescent bariatric surgery center of excellence. I'll address some of the matters that you'll be considering as you think about developing your program. I plan to talk briefly about how many adolescent centers there currently are and relate that to how many young patients are having bariatric surgery currently. And then I'll talk about the reasons why you might consider developing a center. And then I'll spend the remainder of the time highlighting some of the factors that go into developing a program. Right now, according to the American College of Surgeons, there are 843 centers nationwide that are MBSAQIP approved. And of those, 89 are adult centers, which meet criteria to care for adolescents. And currently, there are 6 freestanding adolescent centers. Is that adequate? Well, the data from New York State showed that the number of cases per year is trending upward. But when you look at the patient ages, the increase is in the 18 to 21 age group. The numbers under 18 are relatively flat. And we know that the numbers of adolescents with obesity in the younger age group is much higher than the number of cases being done. Obviously, there are top-notch centers that don't have MBSAQIP approval. So why consider it? Well, as with children's hospital certification, trauma certification, and so on, it acknowledges that the center meets high standards. That may make a difference, particularly in metropolitan areas where, dare I say it, hospitals compete with each other. There also are market factors that may have bearing on reimbursement. And from a research standpoint, being a center gives you access to the MBSAQIP database. Most centers accredited to care for adolescents are adult centers that dip down into the upper teens as part of their purview. Basically supplying surgery for established pediatric obesity care programs. Adolescent centers often arise in centers with organic adolescent weight management programs. Most centers perform far fewer operations than adult programs do, but they still need to meet the qualifications. The number of stapling procedures is less, and still the surgeon has to meet the case numbers. And the programs. So in order to build a center, you need to get things lined up. First, you need your colleagues in pediatrics and pediatric specialties to support you building a program. Second, your partners need to support you. Building a program is going to take time away from other activities that you're doing. They may also be involved in call. And most importantly, you need the administration to buy into this. The administration costs are going to include materials and people. Ideally, you'll have a clinic space that you can share with other team members. Many of the items, like stretchers and beds, are likely to already be available, but bariatric scales, large blood pressure cuffs, seating are things that the administration might have to purchase. In most hospitals, patient doors and rooms should be okay, meeting ADA standards, but your hospital will either need to purchase or rent bariatric beds. These are motor driven so that 500 kilograms of bed and patient doesn't take off going down a ramp. Also toilets, wall-mounted toilets or toilets that have floor support are necessary because standard wall-mounted toilets won't support a heavy bariatric patient. Wheelchairs that are able to accommodate patients are important. Bedside commodes may be necessary. Most existing operating room tables are going to meet the requirements for dealing with weight. However, they may not reach the reverse Trendelenburg position that some surgeons prefer for these operations. Transfer devices, such as an inflatable mat, can make moving heavy patients easier and safer, both for the patients as well as the staff. Not all the imaging facilities can fit the largest patients. This is a list of what the facilities are in our hospital. A larger cost to the administration is going to be the ongoing cost of salary support. The administration should provide at least partial support for the people who are involved in these 4 essential positions which are required by MBSAQIP. Of course, providing comprehensive care requires many more people than just those 4, and ideally the administration will also provide support for nutritionists, mental health workers, exercise or physical therapists, and perhaps even kick in for some additional surgical coverages. In summary, you need the support of a lot of people to build a center. For most of us, the good news is that much of the infrastructure is already there. There will be a definite ask, particularly for salary support. And I should mention that in hospitals, there is anti-obesity bias. So be prepared to deal with that at all levels initially. Other factors also go into certification. Data entry is very important, and the clinical reviewer will be busy inputting data and generating reports. You should plan a quality initiative every year. As far as support groups, we have not been successful having in-person support groups. We've had individuals who meet informally together when they come in for their visits. And then their fees, their annual fees that have to be paid of several $1,000s. So the administrators need to know upfront that that's going to take place. Once your application is in, you'll have a site visit. I think it helps to do at least one complete walkthrough, a dress rehearsal with everybody who's going to be involved. The reviewer is your friend, and when she or he is there, it's also a time to put into their report recommendations for what the hospital should invest in to help you get going. And then you want to maintain your certification. You have to report your cases to MBSAQIP. You have to maintain the standards that are established in the guidebook. You do need to meet your case volume requirements. The fees have to be paid. And then every 3 years, there is a site visit.
Thank you, Jeff. That was a great presentation. Today, I'm going to talk about making the financial case to your organization. So, why do we do this? For us, we know the right reasons to do this because it's the right thing to do. Administrators in hospitals and systems and universities, they look at a lot of what we do as mission-based. A lot of it does lose money, but I know our CFO always says no margin, no mission. So it's really important, if you can, to make a financial case that this is something that's feasible and doesn't have to lose money. Really important is knowing how decisions are made in your organization. Somebody once told me, once you learn all there is to know about a medical center, you've learned all there is to know about one medical center. We are all in different types of organizations and decisions and impact of what we're going to do. So there's all kinds of combinations and permutations, and how this really dices out and how you make this case will really depend on what your actual circumstances are. So as part of that, it's really important to find an administrative partner in your organization. You might have your surgeon-in-chief or your division chief or somebody that's a physician that really knows this and can help you, and that is fantastic. I think it is also imperative that you have somebody on the administrative side, because they can really help you weave the ins and outs of the decision-making process. Not only that, once you learn how to develop this program, you'll be an expert next time around. We're going to talk about making the case for pediatric adolescent bariatric surgery. There's the operation, but there's also pre and post-op. Every program is a little bit different in how these things work. At the end of the day, things that poke and prod and peak make money on the right side of the scale. On the left side of the scale is personnel, and that's usually the non-money generating side. At the end of the day, for the most part, those aspects of the program are going to lose money. And when we look at our medical program, it really loses money. So one of the things that we did is we put everything under one umbrella so that we can show the senior administrators that when you do enough surgeries, we support the whole program, including the medical program, because I firmly believe that without a sound medical program, you can't have a surgical program. So I'm going to divide this up into pre-op, intra-op, and post-op. Now, one of the things that hospital administrators talk about is downstream revenue. Downstream revenue is all the money that you make in the organization from labs, radiology, other parts of the system that can be attributed to what you're doing. The argument for our patients is they're getting a sleep study because they came to the bariatric surgical program. Our patients, will undergo an upper GI series. Many programs do preoperative endoscopy, cardiology consult, EKG, echo. 60% of our patients have sleep apnea, and lots of labs. Then there's the operation. The operation itself makes revenue. You have a patient in the OR on the table. Doesn't matter what anybody tells you, you're generating revenue for your organization. In a lot of ways is what floats the whole boat. So it's very important, and they should consider this. And then post-op, repeat sleep study, repeat upper GI, GERD surveillance, and our patients that get sleeve gastrectomies, and labs, lots of labs. And that goes on for a period of time. Just as an aside, this is an awesome patient that's her pre-op, that's actually her pre-op and post-operative photo. Post-op, she says, everything is awesome. So take homes, administrative partner, institutional decision-making, really have to understand this. And then also understand some parts lose, some parts gain, and how you put that together. That's where your administrative partner can help you navigate the system and understand how, in your particular circumstance, where some people might be employed by this entity, other people might be employed by that entity, the hospital gets all the revenue for the procedure itself. How do you put all that together? And then the other piece is, really don't forget that downstream revenue and credit that to your program so that you can make the case.
Thank you for the opportunity. I've been asked to talk about dealing with insurance companies, which may sound like a pretty dry and uninteresting topic, but actually it's the crux of any bariatric surgery program. Because if you can't get the cases approved and you can't get them on the OR schedule, you're not helping anybody, and certainly your program is not going to be around for long. So the main things I want to go over today are, I want you guys to understand the approval process. Unfortunately, still a lot of these cases get denied initially. So you need to understand the peer-to-peer and appeals processes. And then lastly, I'll go over some sort of tricks of the trade. Before I see any patient in my office, I try to make sure that they actually have insurance coverage for bariatric surgery. We have a couple different ways of making that happen. Often I'll have the patients actually send me their insurance information if they're from out of the region, and then I'll have someone from my staff look into it. I also always ask the families themselves to call the insurance company, speak to a representative. And I feel like it helps a lot with the families to build a sense of trust and for them to see you as their advocate if you come into the first visit already knowing what their insurance requirements are and explaining to them that you will help them achieve those. It's a local regional game, so you do need to know what is covered in your region. And believe it or not, the employer provided plans are even trickier, because if a company decides to purchase an insurance plan from one of the major providers, they don't actually have to buy a plan that includes bariatric surgery coverage. Almost all the plans require a certain number of consecutive months in your multidisciplinary medical weight management program, but most commonly it's 6 months. And then most of the criteria for most of the insurance companies are built around what they require for adults. So you may see that a cardiology clearance or a sleep study or an H. pylori test may be a requirement in the individual plan. Depending on your willingness to change people's opinions and change policy, you can either abide by what they say and just do everything they ask you. Or for me personally, I actually omit the things that I want them to remove from their program. If I think a cardiology clearance is unnecessary for a teenager with a BMI of 41, I may omit it so that when the medical director calls me, I can tell them that it's actually not a requirement for an adolescent in an effort to change their overall policy. So for the submissions, it's best if you just include everything that they ask for, or at least it's simplest and most likely to result in a approval. But there are some tricks that you can use that make it even more likely for you to be successful. First, I usually include a cover letter with an outline of what's included so that the nurse reviewer can actually know that you've ticked off all the boxes you're supposed to tick off. And if in that note you also include what disease you're treating, it often helps. Usually I try not to cut corners. I did actually help get H. pylori testing removed from one of the Maryland Medicaids several years back because I kept pointing out to the medical directors that H. pylori testing is a relic of the gastric bypass era, and eventually they removed it from being a requirement. If you do get a denial, you need to deal with it promptly. Most plans have a window of 48 hours or 72 hours where you can request a peer-to-peer if you get a denial, and that's actually your best chance to overturn a decision. And the reason that is your best chance is because the medical directors in these insurance companies are usually actually reasonable people who want to do what's right for the patient, and they are just constrained by the policy and how it's written for that particular insurer. So if you can give them a good reason why they can overturn their denial, they often will do that for you. The first bullet I list there is be nice, and that is as much for me as it is for you. If you go into these discussions with a confrontational attitude, often the medical director gets defensive and then you don't achieve anything for the patient. So the best scenario is if you go in there with a knowledge of what actually the denial reason was. And then if you actually have data to refute their denial, it's really helpful. So I'll quote a number of papers that I've included here as handouts for you guys to use. Most importantly, the ASMBS policy statement and the AAP policy statement. You can usually use those to help the medical director give their own insurance company a valid reason why, let's say, bone age doesn't need to be done or Tanner stage wasn't documented. And I look at all these interactions with these medical directors as an opportunity for advocacy, or I almost always will tell these medical directors that I will come speak to their policymakers at the next time they have a policy session to discuss adolescent specific criteria. The appeal is the next step if the peer-to-peer doesn't work. And I certainly have had medical directors tell me that, they can't overturn the denial based on policy criteria, but that if I write a strong appeal letter, that will support overturning the denial after the appeal. The appeals process usually has a couple different layers to it. First, there's an internal appeal, which is through the insurance company themselves. And I often put in that letter that I will request an external appeal if the internal appeal upholds the denial. And the reason for that is the external appeal is often a bariatric surgeon who knows a bit more about the adolescent landscape than the internal insurers people. But you should treat it just like when you get a request for revisions from a manuscript you've submitted. You need to have a point-by-point rebuttal for every reason that they use to deny the approval. So what have I learned over the years? Again, it's hard for me to be nice to people sometimes, but I try my best when I get on these calls with the medical directors of insurance companies. I can call them directly when I'm submitting a patient, or I have their email and I can give them a heads up when I'm submitting a patient. And it really does grease the process or smooth the process. So I try to understand the cases from their perspective and give them whatever they need to overturn the denial. Giving them whatever they need to overturn the denial might be, the most successful strategy. So if you can make friends with these guys, you can really help the patients in your area, especially if you're talking to the Medicaids. If you're going to your state Medicaid, you might even want to talk to them before you start a program so that you can get a sense of the landscape and their willingness to approve cases. So I hope that was helpful for you guys. To me, the take-home points are: be informed. So know your field, know it better than anybody else. Be persistent. So if at first you don't succeed, try again. Peer-to-peer, internal appeal, external appeal, and be ready to fight. There are even a couple of times I've taken Medicaids to court to get the patient the care that they needed. So you have to be willing to advocate to the end.
For a graduating fellow who's about to start a job, or someone who's moving to another job interested in starting a bariatric program, how should they discover the intention of that institution and their actual level of interest and support for starting a program?
So I'll go ahead and take a stab at that. I think if you're interested in starting a bariatric surgical program at your new job, you need to be very direct and ask them. And you need to decide if it's something that's a deal breaker for you or not. Certainly to see if they have the resources up front. And if they say that, well, we were kind of thinking about that, that's different than, we've really thought it through and we've, developed some idea of what we need if we do that, and we really want to invest in it. And I think that if you have someone who's put some forethought into it, that's a really good sign. One of the things that you can also look at is what resources they have on the ground. Is there already a medical program? Is there an adult program you can partner with? So I think you need to see what resources they have and what their commitment is. But the best way to do that in a job interview is really to be direct and ask them.
I would add to that, Joy. Look and see what other programs have been started at that place and are existing at that place. If there are no separate standalone programs, PECTUS program, colorectal program, pick one. And you're going to be the first person at that institution to ever build a program. That may be a hurdle that is too difficult to surmount. So you may want to just see what else is big. If there already is a program that does bowel management and a bunch of other different things, then the blueprint is already there and you can just follow that blueprint.
I think it also would be important to find out what your responsibilities are going to be overall. If you're going to be, if you'll have some time dedicated, not analogous to lab time, but just some time that will be yours to develop this program, see the patients, because I think we'd all attest that it's time consuming to do.
How much of your clinical time would you each say that your bariatric work takes up?
For me, I think it probably takes up about 20% of my clinical time.
When I was first starting, it probably took up 25, 30% of my time. But over time, just because that was the way I wanted things to evolve, and younger partners doing things that I had been doing for a long time and was happy to let them do, it now takes up about 75% of my time.
But I don't want people that are interested in this think that it needs to be 75 or 80% of your time, because Evan and Jeff, you both are somewhat anomalous.
I think that's exactly right.
You're only going to spend 5 or 10% of your clinical time doing it. You're never going to get your program off the ground.
You mentioned, as sort of an incentive for the hospital administration or the health system administration supporting this program, to lay out for them all the downstream revenue. I, at one point, had difficulty getting a hold of that data because of the silos. But even so, if that's somehow not enough for them, are there other carrots you can offer? I mean, I think if you're in a reasonably large city at a bigger institution, you could point out that you should have such a program to serve the community. Is it kind of legitimate or reasonable to cite the U.S. News and World Report and some of these other public scoring systems that the hospitals seem to care about?
Yeah, the hospital administrators do like U.S. News, and they like to be able to check a box, so that helps. And again, it's the right thing to do. It's, you can cite the statistics on the epidemic and how many patients are not being treated and all the other diseases they're getting. And in the end, like Jeff was saying, we were very similar. It's like, we went to the endocrinologist, the cardiologist, and they all had this stuff being done in very disparate ways, even in the medical program. We were able to bring it all together. A lot of those folks that were seeing those patients didn't want to see them, so putting them in one place was much more efficient treatment for the patients on the medical side. Even, it absolutely is the right thing to do. And you're not going to be able to get the numbers on like how much money they make on an upper GI, or they can't even tell us how much money we make on an operation. Those are actually like anti-kickback laws and everything else prevent us from knowing that data. So there's a lot of blinders on it, but what I can tell you is that if you do enough cases, the hospital will make money. And that's the thing that really made me realize that, is realizing how many adult programs there are out there that are doing really well.
So to me, so 2 points. One is the U.S. News and World Report. We should all be advocating for a separate obesity care box. The other one is money. And it is a fallacy that bariatric surgical programs at children's hospitals lose money. It's completely untrue. I actually co-manage the medical program, even though it's not under my surgery center. And we do everything possible to make it so that their program actually is close to break even. Because then I don't need 20 cases to break even, because I've already broken even. So now every case I do is profit. As much as they like to think that they do things for the right reasons, they do things for publicity and for money. And those are your two hammers to hit the administration with.
The other is competition. The fear of loss is always greater than the desire for gain. And so if you can put in the administration's mind that if they don't have a program, then they're going to go across the park to Sinai or downtown to NYU, or then it catches their attention, makes them think twice about it.
The last question I had, kind of not directly related to the substance of your talks, but there's interest in knowing if you guys have and are willing to share, or if you know of any obtainable templates for letters of medical necessity and insurance appeal paperwork.
The ASMBS has a lot of resources on that. I don't know if they have exact templates, but they do have a lot of resources for that I believe are on their website. And I'm happy to share anything I have. What I find is that every insurance company is different with what they're looking for. But it really is when they say that, well, we need a letter of medical necessity that says that this patient has tried everything else and that there's no other options for this patient, then you actually just use those words that they gave you and spit them back at them. And that's usually the most effective way to do it.
And I'm happy to give anybody all my templates to everything. You can have my order sets, you can have it all. I try to predict what the pain points are going to be and address them in my submission. Every time I get a denial, I add that template, that phrase into my note, so that now my notes have almost every reason for a denial built into it, so that I don't have to deal with it later.
We basically give them everything, and the more you give them, the better.
We do about the same. We send everything. There's letter from me, letter from the medical director, the mental health clearance, notes from all the nutrition and GI visits, and then every piece of data that's not only electronic and printed out versions of those that are. It's about a centimeter thick is what gets to them.